Good morning or afternoon, everyone, depending on where you are. This is Bethel Araya with JBS International, and thank you for joining us for today's webinar, Medication-Assisted Treatment for Opioid Use Disorder, Philosophical and Practical Considerations. Before we begin, I'd like to review some housekeeping items. Due to the high number of participants on this call, all participant lines will be muted for the duration of this webinar session. If you have any comments or questions, please submit them at any time by using the Q&A feature. To open your Q&A window, please click on the Q&A icon located in the bottom center of your Zoom window. If you experience any technical issues during this webinar, please message us using the chat feature, which is located at the bottom center of your screen, or email us at rcorp-ta@jbsinternational.com. At the end of the presentation, we request your participation in a short satisfaction survey that will appear in a pop-up window in the middle of your screen. We thank you in advance for your participation in this webinar, as well as the satisfaction survey. Lastly, this is a recorded event, and your participation grants consent to be recorded. The recorded webinar and PowerPoint slides will be available and sent to participants at a later date. Today's presenter is John Roberts, Technical Expert Lead with the Rural Communities of Opioid Response Program, Technical Assistance at JBS International. John, I'll turn it over to you.
Thank you, Bethel. Thank you for joining, everybody. It's good to talk with you today. I do want to tell you, as we start talking about substances, we have had a substance hit the streets here in Bethesda, Maryland in the last couple of days. It's a yellow powder called tree pollen. So I've been trying to cope with that. So you may hear me pausing every once in a while to grab a sip of water as we get through. So I will try to keep my throat open long enough to get through this and then take some of your questions. So prior to joining JBS about 5 years ago as a technical expert lead, I've worked in a variety of settings in both mental health and substance use disorder treatment. For the past 30 years, I've worked in primary care, jail and work release, drug courts, acute psychiatric and long-term forensic psychiatric hospitals. I've worked in child welfare and foster care. I've worked with office-based MAT programs and methadone OTPs and quite a few standalone therapeutic communities and in and outpatient substance abuse programs. So I'm hoping to bring that broad range of experience to the discussion today. Although when I go over my experience at this point, I think of my first supervisor who told me when I started in the field that he said, you know, John, some people have 20 years experience in the field and some people have 1 year of experience 20 times. So I'm hoping it's a former for me and that you're able to benefit and gather some information from this that will be helpful in your communities. So this is a goal from the original funding opportunity for RCOR. I changed it a little bit. It was reduce morbidity and mortality, which is a little harder to explain to your kids when they say, what did you do at work today? So I just switched it up a little. Keep people alive and well in their communities by helping the consortiums address prevention, treatment, and recovery from opioid use disorders. So I want to give you some topics to think about today as we go through that may fit in your communities. As we're talking about this, I do want to say that you know what works best in your communities, and I wouldn't presume to be here and put a bunch of slides out and say this is how it has to be or this is the best way to do things. But I'd rather think about it in terms of two questions as you hear some of the things I'm talking about and look at the slides, and that is, have we talked about this issue or do we need to talk about this issue? Sometimes we assume we're all on the same page, especially in community consortiums, but we may in some senses have different ideas and goals. One example for me is that I worked in a rural community where the opening of our drug court just happened to coincide with the opening of a new jail. So everybody in the community we were committed to having a safe community. We were committed to public safety, but we had some cross goals there on how to work with people with opioid use disorders. The sheriff wanted to fill beds, and we wanted to fill our treatment slots in the drug courts. So we eventually had to work out a system where people, while they were still incarcerated, could start treatment, drug court treatment, and then be guaranteed a slot. On the day they were released, they would come to group that day and have credit for that amount of treatment we had done. But it took some time to work that out and figure out how we were going to meet these two goals and how we were going to work with corrections and law enforcement to make that happen in a good way. So as you're aware, of course, in your planning grants, you had the ability to work on prevention, treatment, and recovery, or you could pick one. Today, primarily, I'm going to be focusing on the highlighted areas, which is the first part of the treatment activity, which is implementing or expanding access to evidence-based practices, EBTs, for opioid addiction and opioid use disorder treatment, such as MAT. In 2 weeks, we're going to be doing a broader webinar on evidence-based practices. So I don't want to spend a lot of time reviewing evidence with you because that's coming up in the next webinar. But I do want to talk about some of the issues that may be important for you to discuss going forward. As we talk about this, I know that in the audience, people work in different areas, have different perspectives. Some people may be very, very familiar with MAT and some may not. So I'm trying to walk that line of doing some MAT 101 stuff, but also going a little bit deeper. This is a broad overview. So with that in mind, I've put a resource section with links at the end of the presentation. That's just my bias. I like to do that, kind of try this on, see if it fits for you. And I also want to say, in looking at this, if there's any particular topic or slide that you want to hear more about, you're certainly welcome to let us know. And you know, we can come back to any of these topics because, as I've said, some of these things I'm going to be talking about are things I used to do in a 2-day training. So you can get to the point where you could spend a lot more time on any of these. And I don't want to frustrate anybody by talking about something for 2 minutes and moving on and never coming back to it. So feel free to let us know if you want to come back to something. So I'm not trying to induce eye strain with this. I think as we send the slides out to you, you'll get a better look at this. But this is the R-Corps Planning Cohort 1. So 95 grantees serving 592 counties across the country. The reason I wanted to put this up is just to, oh, and there's a second planning cohort on the way in June. So probably maybe about the same size, maybe a little larger. So in looking at this, it just encourages me that there are so many good ideas out there and so much innovative stuff going on and so many grantees already talking and sharing ideas and helping each other out. And we're really looking forward to meeting you in June. So on those days when you may feel isolated or discouraged or is anything happening out there, this is just to let you know that these changes, these innovations, and the work that you're doing is going on all over the country. A lot of times people like to show those maps of how the opioid epidemic spread from 2002 on to the present. You just see all these colors explode on the screen. So this is our response to that. Obviously, it is a response. Something difficult happens first, and then we respond to it, and it takes a while to catch up. But I just wanted to put that out there to let you all know that there's a lot of folks out there working on this problem. I'll apologize in advance for this one, but my point is that as you're working on planning, and I know it's frustrating sometimes to work on planning when you have something going on immediately and there's a crisis in the community, but I think one of the things that planning can do is make us look at solutions that are going to endure over time. That's something I'll talk about in the next couple of slides. But for right now, just that idea that the things you put in place today and the things you put in place in your planning grant don't have an expiration date. They will help with the opioid epidemic, which is what we're talking about now. But as we know, there may be something coming behind that. In a lot of communities, there already is something coming behind that we're going to have to deal with. So the systems that you set up and the infrastructure that you set up now can really go forward in the future for quite a while. So very quickly, this is probably going to be the world's fastest history. I don't want to spend a ton of time on this, but just for some context, we know that at the turn of the last century, there was a lot of opioid use and overuse of opioids. And then in looking at how treatment started or how people started to look at that, I just flagged some things starting in the 1930s, the U.S. Narcotics Farm, which is in Kentucky, where Obviously, it was a research and training and also treatment program for people, and then also federal prisoners. So there were a lot of things done that were innovative at that time, and there were a lot of things done in that setting that we would never do today. But I just want to recognize that as an indication that people were recognizing this as a problem and trying to find ways to address it. Also, the 1930s was the founding of AA, the 12-step program, so much that you still hear about today. In the 1940s, obviously, as Americans, we were kind of busy with some other issues. And then when we move on to the 1950s, you hear about a phrase you'll still hear, though not as often, 28-day programs or rehab. And NA coming along in there also too, based on the 12 steps of AA with a few revisions. You also see the development of peer-driven therapeutic community models in the 1950s, usually aligned with criminal justice or criminal justice involved clients who were working in a peer-based model, and that was the peer-based model where you would start as a client in the program and then progress up through phases and then oftentimes become a counselor. So this was a peer-based model that's been around for a long, long time. Methadone has been around for a long time, but in the 1970s was approved as a treatment for heroin addiction, as dispensed in opioid treatment programs. We'll talk more about that. In the 1970s, there was an increased advocacy for addiction and as a disease and increasing health insurance coverage, a lot of times for the rehab type 28-day programs. In the 1980s, when I started in the field, there was still a lot of fragmented services. For example, alcohol and drug services often were separate, and we know that people don't break out that way, where you only use one or the other, but a lot of times administratively and clinically, those programs were separate. The 1980s also brought us another epidemic that I'm going to refer back to a couple of times, which was the crack cocaine epidemic that we had to deal with. I do want to say, as we talk about these epidemics, what a lot of people talk about, there's a crisis and then there are opportunities in that crisis. But I just want to stop for a second and say that before a crisis becomes an opportunity, it is a tragedy, and people get hurt, and there are struggles, and there is trauma, and there is grief, and all those things happen. And these crises seem to bring out the best of us and the worst of us a lot at the same time. So as I talk about these things and how they changed substance use disorder treatment, I don't mean to skip over that step, and I won't. When you see things like the crack cocaine epidemic, you think about mass incarceration, mandatory sentences, and a lot of ways that are impacting families through generations based on what happened in that decade. On the other side, you also see expansion of women's services, because there, much like today with the opioid crisis, there was a huge influx of children coming into child welfare services due to their parents having difficulty taking care of them. We started to see the development of specialty services for different subpopulations. Obviously, I don't have it down there, but the AIDS HIV crisis also exploded at that time, and as again I mentioned in struggles, people had to really, really fight for their rights and to get things changed. As a result of mandatory sentencing, also you saw in Miami, Florida, the first drug court established in 1989. So there were some responses in our treatment system, as slow as they came, to start looking at some of the societal changes and some of the different ways we had to cope with these situations. 1990s, the onset of managed care, and what we saw was a lot of questioning about the 28-day model, a lot of questioning about inpatient treatment and people having to go to rehab, and that always being the starting point. So you started to see, although people like to vilify managed care in a lot of ways, you start to see them asking questions like, can you show outcomes for this? Why are you starting here? Why is it 28 days? Why is your continuing care program 3 months? Why? What's your basis for that? And I think those are questions we often still struggle to answer today in our field, and I think it's something that led to some of the other bullet points on there, which was expansion of recovery housing. If people couldn't get out of their environments and go to rehab or a full-time program, very often you'd see these hybrid models where people lived in the Motel 6 across from the treatment center and went over for care 7 days a week. So In addition to that, you also saw the expansion of the recovery advocacy movement as people began to advocate for themselves in recovery. As we know from the 12-step programs, some of the one of the traditions is to maintain your anonymity in public levels, and the recovery advocacy movement kind of turned that upside down and said we're not going to be defined by stigma and discrimination, and we are going to go forward and talk about the changes we've made in our lives. So you see that expansion. You start to see motivational and person-centered strategies being brought into substance use disorder treatment, which much needed. And then we get to the 21st century, and some of the things we're going to talk about today: expansion of MAT, a more inclusive definition of recovery, the integration of co-occurring disorder treatment, mental health, trauma, and like I said, when I started in the field, if you were on medication, even antidepressants, that was a barrier to admission to substance use programs in a lot of settings. If you had an alcohol or drug problem and were seeking mental health treatment for depression, you were actually tasked to demonstrate sobriety for anywhere from 1 month to 6 months to 12 months. So as I'm looking at this, and I see us making progress, and I see things going forward, and I see what's happening now, again, with pausing and taking a look at this is a crisis, it is an epidemic, and there are tragic things happening. The fact that how can we design our systems to cope with this and come out of it in a good way. So as we wade into this, I just want to acknowledge this, that it's an interesting statement. I mean, that we really, not the most person-centered language there when he's talking about addicts, but this was written quite a while ago. So the thought is that we have to consider ideology. We have to consider that people are very, very passionate about alcohol and drugs and recovery from it and treatment for it and how to handle it as a public safety issue. And as we're talking about this, just to be aware of that. Again, I just flag this as just a sampling of some of the thoughts that are out there and some of the things we're working under and some of the different ways that people view what addiction is and also what the solutions may be. So this is one definition, and as a healthcare provider for many, many years, I mean, this is the one that we tend to go to. We talk about addiction as a disease, and we're aware that as a healthcare system, we are taking this on, and that it is a chronic relapsing disorder. I think in talking about back in the 80s when people would go to rehab, the thought or the presumption was, at least an underlying presumption, was that this was taken care of, that if you went away to treatment and came back and went back into your community, that you had received enough skills and tools to be able to handle yourself from there on in, and that the understanding that there could be a recurrence, or that was a natural course for many, many people, was not as common as it is today. So this is some information. Again, this may be a little hard to read, but when you get the slides, it should come out better. This is just another attempt. It was done by NIDA just to recognize that with addiction as a medical disorder, that this is the way this works, that there are recurrences of illness. It happens across the board with chronic illnesses. And a lot of times what's different is the perception of people with addiction and what that relapse or recurrence means, as opposed to somebody with asthma or hypertension or diabetes. The way the system, although we talk about it as a chronic disease, the way the system deals with these issues and deals with addiction differently is still something I think we have to overcome. And I'm going to talk about that more a little bit later. I think this young man was someone I worked with in drug court, and as you're reading that, you may ask for people who work in drug courts how somebody who has a history of armed robbery got into a drug court, but just as a side issue. But that was not something we knew about or was disclosed or he was charged with. So, but I think this says a great deal, even as an internal perception, about how people view addiction differently than other chronic illnesses because of just the cross currents of the way it cuts across socially and cuts across our community and society at large. So I think I'll just let that stand on its own. So as I'm going through this, yeah, I want you to remember the two questions about have we talked about this? Does our community need to talk about this? This is a definition of recovery. So if we flip from addiction and start talking about recovery, this is one SAMHSA put together. They put together a consensus panel years and years ago and came up with this. It's a nice definition and has a lot of areas that are, point well taken. However, one of the things as people started looking at these definitions is that when you start defining things and you start putting the characteristics in there, you may start excluding people who say, I don't define it that way, or the way I think about it is very, very different. Some people say, well, I don't use peer support. That's not one of the things I do. And or although as a provider, this always, the cause of anxiety for me, people say, I don't want to address my trauma. I'm doing okay, and I'm going to keep that where it is. And as you see this, and as you start to have a consensus panel define what recovery is for people, you start to see that you're going to run into problems with people who don't fit this definition. So I like it. It's really well done. But I think we have to be aware that people may have different impressions about that. More recently in the recovery movement, these are just some quotations I flagged to think about because these are, if you're working with a recovery community, these are some of the things you might hear, and these are some of the things that the recovery community is promoting and taking a look at. So given that, again, I just went through those definitions of addiction and recovery just for you all to take a look at. Has our community talked about this? Is this something we need to talk about? How do we line this up among our constituent partners? And again, I'll talk about that a little bit later as well. So here's one thing that I like to think about over and over is that there is no perfect treatment. There is no perfect treatment setting. And we have to really think about not going in one direction or the other. I know there's some strong opinions about MAT, but in thinking about this, I don't think anybody's advocating for putting everybody on MAT. And I know there are some folks that say, well, we don't want that in our community, and we want the resources to be used for what we would consider abstinence-based treatment. And that's the way we want to go. But my thought is that the more options we have, I think the better we'll do. So we'll talk a little bit about how your community can incorporate that, what your community will tolerate, what your community wants to do. However, one of the things I want to stop and say is that as a provider, one of the most important things you can do is look at assessment. And what that means is you consider people as individuals, and you take a look at different options for them. For example, if I had, let's say, an 18-year-old who was injured playing football and had been misusing opioids for 3 or 4 months, and looking at that and saying, well, the only option we have in our community for opioid use disorder is an OTP or long-term methadone treatment, that might not be a great fit. Or you have, for example, a 33-year-old pregnant woman who is on bed rest, but is going out to get drugs every day and not complying with that or not adhering to that. What is the best move there? You can take a look at, say, a 54-year-old roofer who was severely injured in a fall and has been to an abstinence-based rehab 3 times, and when he comes back each time, quickly resumes use of prescription medications and heroin as well. So he has a chronic pain issue. So what's the best those 3 people are not going to need the same thing. So as we assess, what are some of the things that we can take a look at? So this is just a kind of a quick snapshot of some things that you would want to consider at those times. Again, this may be a little bit of an eye strain, but I like this visual. It is from NIDA, and it's their Principles of Drug Addiction Research and Treatment. And it's a nice snapshot picture of when you're assessing a person and what services they might need, what to take a look at. Obviously, it's a little outdated. There are some things we would definitely want to add with HIV/AIDS. We want to add infectious diseases as a whole. We would want to take a look at a recovery plan that's matched up with the treatment plan, but that's in there. We'd want to take a look at culturally competent services. So there are a few things on here that I would change at this point. But how it helped me when I was seeing people was it just helped me understand that I need to ask about all these areas and I need to figure out what the plan is. So again, MAT defined, this is a quote from a peer counselor that I worked with a while ago. And one of the questions he would get frequently as people came in is, well, can I just have the medication? Why do I have to go to group? Why do I have to do all these other things? So that was his very brief answer, but I think it's a good answer for all of us in that a lot of times the perception of MAT and how MAT is defined is that it's medication and medication as a standalone. And that's not the ideal way to go forward with that. And I know there are certain situations in frontier or remote areas where you may have one provider who's prescribing buprenorphine and say, I'm the only game in town, I'm doing the best I can do, but I can't provide all these wraparound services. I understand those extreme situations. However, for the most part, what we're trying to look at is MAT as an adjunct to treatment. MAT as a way to give folks breathing room to reduce the obsession with drug-seeking behaviors and the cravings so they can go on and learn the skills that they need to learn to be in long-term recovery. So I just want to say as a larger societal issue, I think a lot of times, for example, if you just watch the evening news, what you'll run into is pretty much every other commercial is a medication ad, and it has a story arc, and the story arc is someone's having a difficult time, they start a particular medication, and within a matter of time, they're functioning a lot better. So it's a great story arc. It takes about 30 seconds to go through it. I'm not knocking it. I'm not knocking medication. But I'm saying I think a lot of times we tend to think of pharmacological solutions as a standalone and the way to go, which was part of what got us into this in the first place with the prescription epidemic that came along as the first wave. I do want to say also when people say, can I just have the medication and I'll take it from here, I don't mean to put that in the category. I know a lot of people say, well, that's what addiction is. I mean, people are always looking for the easiest way out, but I would say that's a human tendency, and that's something we all do. I know I've had, people say, well, my doctor told me to change my diet because my cholesterol is too high, or I could just take medication. So I said, give me the medication. So I think that's something that's true across the board, as we talked about with pharmacological solutions. We're sometimes looking for the easiest thing to do and not all the work that comes behind it. So I just want to flag that as something that I think across medical conditions, and certainly for me, that's one way to think about it. So I've paraphrased opioid use disorders in here, and I don't want to spend a lot of time on this. It's a paraphrase of the DSM-5. I only wanted to put it on here to make the point as we talk about MAT. We've talked a little bit about the definition of recovery. We've talked about that it's an individual decision for what it means to people. But one of the things to think about as we ask about MAT, we confront some of the myths that, well, it's just trading one drug for another, or people aren't able to function, that these diagnostic criteria are things that by using MAT, that you want to remove. In this case, what you want to do is say, are we experiencing the absence of this? Are people functioning? Are they meeting their role obligations? Are they not putting themselves in physically hazardous situations? Are they not subject to infection from needle sharing and things like that? So at the most basic level, and hearkening back to what we talked about at the beginning about reducing mortality and morbidity and having people live healthier lives, is that what's happening with this? And if you are removing these symptoms and putting people in remission, I think that's a positive thing. And it's something when you want to put the arguments about recovery and who's in recovery and who's not recovery aside for a moment to take a look at, is this giving a person an opportunity to be a functional member of a community, a good citizen, be productive, and participate in things that they may have been marginalized from for a long, long time? So very quickly, these are the, this is just a snapshot of the medications that are approved. And as we talk in rural communities, I mean, obviously there are up and downsides to each one of these. Methadone is dispensed at opioid treatment programs. I know there are some very limited exceptions. There are some states that have actually mobile methadone vans, but that's something that's no longer permitted to go forward, although some treatment systems are grandfathered into that. So for the most part, in a rural community, this is somewhere you have to go every day to receive your medication. It's a daily visit. At some point along the line, you can get take homes. Could be 6 months, could be 12 months. But that is one of the barriers, is that these programs require transportation. They require people who aren't close to them to come in every day. In 2002, buprenorphine hit the scene, and I'll just say there are so many different generics and so many different products under buprenorphine that I just left the generic up there, because there are all kinds of different ways that it's administered. There are all kinds of different ways it's formulated. Some formulations have naloxone in them, which is intended to discourage adulterating, not adulterating, but administering the medication in a different way, crushing it up and snorting it or injecting it. So whether that's an actual deterrent or not is goes back and forth quite a bit. But this medication can be dispensed in an office-based setting. It can be dispensed from an OTP, but most often dispensed from an office setting, can be dispensed from an emergency department, and requires that the practitioners be waived. Some people say waivered or waived. So they have a training that they have to take. Could be doctors, physician assistants, or some categories of advanced practice nurses. And in that sense, it's a much more flexible medication. I think, as we're all aware at this point, there is a diversion potential for that medication. And in a lot of communities, that's become a real negative stereotype, or something that makes thinking about incorporating buprenorphine into the community a real head scratcher, because it is a medication that's being diverted. The third is the naltrexone injection and extended release, so it's good for about 30 days. It is not a opioid. It doesn't have any opioid properties in it. So for a lot of folks, this serves as a nice compromise if they're concerned about using MAT that's a partial agonist or a full agonist. The downside, and I'll talk about this in the next slide too, is that you have to have opioids out of your system for before you can take the injection, or else it's going to be very, very unpleasant. So one of the concerns about this is that it doesn't provide the immediate relief that these other medications can when people are in withdrawal. So again, hearkening back to the slide that there is no perfect treatment. Just a quick detour on MAT. These are some other medications that are approved for tobacco use disorder and alcohol use disorder. And again, very quickly, these are just other terms that you may see for MAT, especially with the opioid substitution, opioid assistance, opioid replacement. And I just have a comment down there that, you know, in other medical conditions, we don't separate out medication-assisted or medication-supported from just treatment. So hopefully someday this will just be something that's discussed as treatment. Again, I'm going to blow through these slides pretty quick because you're going to see them again during the evidence base, but I just wanted to provide, and I know we have some issues sometimes at the bottom of the slides, but there are references here for some of the evidence. I didn't want to totally bypass the evidence for when you look at MAT versus abstinence-based treatment. And then sometimes people ask about, well, what's the head-to-head on buprenorphine if people come in and withdrawal and work with that and also work with naltrexone? What's the difference between the two? So this is just a quick slide about that. Again, I don't want to spend a lot of time on this. You will hear it again in the evidence-based presentation in 2 weeks. But they work out pretty much with the same level of success. But again, with the extended release naltrexone, you do have to spend time getting opioids out of your system in hopefully a safe environment. And that is something that leads to a lot more dropouts than people who are coming in for buprenorphine and getting relief within a couple of hours in a lot of cases. The costs are higher for extended release naltrexone during the first 24 weeks, but then they tend to flatten out over time. So that's the difference between the costs. I mean, obviously, when you're talking about medication-assisted treatment, there are costs to it, and I know those can be barriers too. And I do have in the resource guide a little bit about what's paid for in what state by Medicaid and commercial insurers. But that's something that's a state-to-state issue. So some philosophical and practical considerations along the way. Again, the thought, have we talked about this or do we need to talk about this? The first thing I would say very, very briefly is if you are considering implementing or expanding MAT in your service area and you get a lot of questions from providers about it, make sure to take a look and see if those are actually philosophical problems with it. That is, my values don't line up with prescribing these medications. I don't think it's the right thing to do, versus just some things that can be ameliorated by helping folks overcome these barriers about how do I get reimbursed? How, if I'm a workplace person, how do I deal with, are they going to test positive for opioids? How can we work on that? Are people going to be in withdrawal in my waiting room? Or I don't have time to do the counseling. I have a very busy practice. I'm willing to prescribe the medication, but I don't think this is going to work out for me. So I would say take a look at that as an initial thought. These are things that I've just pulled from a variety of your all's community surveys and provider surveys, focus groups, key informant interviews, because one of the things obviously you have to take a look at is, you know, what's the temperature in our community about this? How do we view it? And if we decide to introduce this, what exactly are we going to be dealing with as far as people's concerns about it, and how can we deal with that? This is something I've just included as a reference guide, and it's something developed by HRSA and SAMHSA years ago. It still stands up pretty well, though, and it's an organizational readiness assessment for MAT. So if you have an organization, a treatment organization that's thinking about incorporating that, this is just kind of a quick discussion guide. There's some check boxes on it, and it helps you take a look at how would we do this? What are some of the barriers that we're facing? And this to me is key as well, and that is assessing your partner's attitudes, because if there's non-alignment on this, if you as a treatment center providing MAT, but that's a barrier to recovery housing, it could be a barrier in people's level of comfort in 12-step meetings. I did attach the NA guidance on medication in the resource section, which talks a little bit about people on MAT and the approach to them as they're attending NA meetings. So these are all things to take a look at, and presumably you have consortium members from these various constituencies. So how does this line up? Does law enforcement and corrections understand this? I also put in the resource section, there is a fair amount of case law on housing discrimination and MAT. There's some case law on correctional facilities and MAT and people being barred from using MAT in correctional institutions. There is some case law on that, so definitely take a look at that at the end. So this is leading up to a pitch I want to make, regardless of where you are and where you're working, and that is to really think about including folks in recovery. Also, people who use drugs, although, you know, there's the caveat that someone who's actively using drugs in a small community is probably not going to be that willing to come into your consortium meeting and sit next to the sheriff. I understand that. I also want to recommend thinking about bringing in people in recovery and their loved ones early in this process of system change as you're thinking about addressing your system of care. I did attach the peer support toolkit, which just is a great resource. It has just about everything in it. It was done by the city of Philadelphia, and the first thing I will say is I know that this is you are rural grantees, and I'm not comparing you to an urban environment. What I am saying is that this is scalable, and some of the values and the mission of this document and some of the ways to think about incorporating recovery and peer supports into your system are applicable across the board. The three approaches there they talk about are just you can hire some peer support specialists and sprinkle that into your existing treatment system. You can work in a selective way and use certain programs that are more recovery based, or you can transform your system. That is, be informed from top down and bottom up on recovery services and how to incorporate that, and how to use peer support, and how to build your system based on information from the people who have used it or are in recovery, and understand what it takes and how difficult it is to walk in that building and get help. In thinking about this, one of the questions I get very, very often is, what about other substance use? And as a provider, I understand that bind that people are in, especially in a child welfare agency where you're a child welfare worker and a person says to you, I've stopped using opioids. I got it. I know that created major problems in my life, and I'm willing to, take a look at that and do whatever it takes to not be in that situation anymore. But I do enjoy, or I use marijuana, I use cocaine, I use alcohol, I use other drugs. And just the quick editorial is that as a provider in a system where a lot of people are mandated into services or have to do certain things to get the things in their life that they want back, I don't think we've addressed this as best as we can yet. I think this is still an area where in your community you can say, how can we talk about this? What do we need to talk about? And have we talked about this? And treatment systems are usually arranged so that they are talking about abstinence from all substances. So, and if someone's made an agreement with the judge that says, I will abstain from all substances, then as a provider, that's the way I have to work with them if they're going to work in that system. In other scenarios, I think, Robert said in his presentation 2 weeks ago that you look for small wins, you look for positive change. And if you're not familiar with this model, I think everybody is at this point. It works equally well for systems change and for personal change. But it is to think about if somebody says, I'm willing to discontinue opioids and do whatever it takes, but I have thoughts about other drugs, or I don't feel like that's a problem for me. This is a great model to jump in and just talk to them about where they're at with that. I think people tend to look at it as, well, people are in pre-contemplation, or they're not thinking about change, or they're in denial, as opposed to separating out what folks are saying to you and what they are willing to change and what they're struggling with changing. So this is a way to kind of break that out. As a provider, when someone would say to me, I'll discontinue this one drug, but I'm going to continue using other ones, I tend to take a look at what's driving that and what the motivation is and what's going on with them, and talk to them in a respectful and curious way about it, and use this model to think about, can we move them along? I'm looking at the time and thinking we promised to send you the answers to questions we don't get to, and we promised to send you the slides and responses and any other resources you might have asked for during the presentation. So I'm gonna send this to you all, but I just want to let you know it's a training exercise I used to do about what happens when somebody in substance withdrawal walks into an urgent care medical setting versus when somebody with chest pains walks in, and think about the way that the providers respond, think about what they're thinking and feeling, and think about how they're looking at that and what their plan is based on those two scenarios. So I will send you that in more detail. I'm just looking at the time. So these are the resources as promised. Again, if there's something you want to go into a little bit more in depth, we can do a topic on that, or we can send you more resources. Just let us know. I wanted to be inclusive in this because I know this was a broad overview and we really didn't have time to dig into any of these issues individually. One of the things I would ask is, because we're all working together, because there are 95 grantees, if you've come up with some strategies, or in looking at the slides or in hearing the presentation, say, we figured that out. If you want to figure this out, here's the way we did it. I am happy to collate those and get them to you, maybe for the meeting in June or earlier if I can. So if you do have ways that your community came together on this, which is something that can be a divisive issue, just please send that to us, and we'll take care of it for you. Okay, so we made it through, and let's take some questions.
Thanks, John. So at this time, we will begin the Q&A portion of this presentation. If you have not done so already, please submit your questions by using the Q&A feature located at the bottom center of your screen. We will also now launch the poll that will appear in a pop-up window on your screen and will include a few short evaluation questions. Please take a few moments to complete the survey.
Okay, so I'm looking at the questions, and somebody commented that medication-assisted recovery, MAR, is also a very frequently used term. I didn't have that on the slide. Thank you very much. And oops, let me leave that poll. We also had some thoughts about mobile methadone. That people discuss methadone. It's a long-standing MAT as kind of the gold standard. It has the best retention rates. The sticking point has always been you can't go there. I mean, you have to go there, and you can't do it in any other way. So we have very limited mobile methadone with good results here. It's being done in Europe. Robert mentions Portugal, but it is a good model. The barrier to that is the DEA's concerns about diversion and the DEA's concerns about safety, actually. So you can use what we call the buprenorphine ban or the MAT ban in other settings, but we really can't, at this point, that's not going any further with mobile methadone. People do want to have us flag the fact that these medications can be expensive, and reimbursement, if you've ever looked at some of the utilization reviews on these and reimbursement for these medications, the limitations to them, the fact that in some states people have to try abstinence-based treatment and fail at that before they can get medication-assisted treatment, that the naltrexone injection can be very, very expensive, and that is a barrier. Okay, law enforcement in our service area are saying meth is trending back because it is perceived as safer than opioids if there is not the threat of overdose. How can hubs and the hub and spoke model best address this? Are they equipped to address this trend? I'm going to give a semi-glib, quick answer to this, but I think it deserves more than that, so I just want to say that. one of the things I've heard, especially in the Midwest, is that as meth is trending back, that it is starting to be laced with fentanyl, which means that it is not safer than opioids in a lot of cases, that there is a severe risk of overdose with that. When I mentioned the crack cocaine epidemic in the 80s, how can Hubs and hub and spoke model best address this? I mean, it's reminiscent of withdrawal stimulant use. The crack cocaine use resulted in people experiencing psychosis, people being very, very agitated, and how that was handled in a lot of cases was very secure psychiatric units with substance-induced psychosis definition. The good news is that folks would clear up really fast and be ready to move on in their treatment. The difficult thing was just that those were some very agitated people. They were having a lot of difficulties. Experiencing psychosis is a very frightening thing, especially for somebody who has no history of that. And it really burdened the treatment system, and a lot of times burdened more the mental health treatment system, which was separate from substance abuse and still is in a lot of cases. So I will research some more thoughtful answers to that, but that's a very quick answer to that, is that I think we may have to learn from the past, and that we have to keep people safe and secure as they go through that, and that it is a very, very difficult withdrawal. Let's see, any media or marketing tools to highlight, help sell MAT in your community or persuade people that it's safe? Yeah, I will put those together when we send out the resources. Why does the DEA require a waiver to, I'm not laughing at this question, it's not funny. Why does the DEA require a waiver to prescribe Suboxone but not opioids? Has anyone ever overdosed on buprenorphine? The answer to that is yes, as buprenorphine is more often diverted, usually in combination with other drugs, especially benzodiazepines, which will lead to respiratory depression. I think it is an overdose risk. When Suboxone started up, and to give a serious answer to that question about anybody can prescribe opioids, but there are restrictions on providing Suboxone, is that when Suboxone first came about, by putting naloxone in there, which is the medication that Robert talked about, to basically strip opioids out of your receptors really, really quick, they were attempting to deal with diversion. They were attempting to deal with patient limits by having physicians, at that time, physicians only prescribed for about 30 people, and then eventually going up to 100, and now eventually you can go up to 275. But what they were trying to do was reduce diversion, and they tried all these different ways they could think of. So I think it's okay that there are these waivers and that people need to be educated to prescribe that. It still hasn't totally solved the problem, but they were trying to be thoughtful about that at the beginning, and they didn't want a repeat of prescription opioid problems with the buprenorphine. Suggest measuring attitudes in the community. Yeah, I will, when I send out the resources, we capture all these questions and we keep them, so I'll be able to provide that to you. Great question. Suggested MAT time before you start cutting down. I think what we learned early on with this was that just detoxifying people or doing withdrawal management with MAT for 2 or 3 weeks, like a social detox model, was very, very ineffective. The recommended timeframes I've seen recently are about at least a year. And as we know, people tend to stay on, especially methadone, much longer than that. I mean, we don't know everything we need to know about the brain. It's a very complex organ. However, we do know that these are changes in the brain, and that may be permanent. So I don't think there's any gold standard on 1 year, 2 years, but the recommendation is about a year. I think at least with buprenorphine, and then longer than that with methadone. And there's all kinds of interesting innovations you can do, whereas you're taking people off those medications, you can switch to extended release naltrexone, which a lot of folks have done. It's become a lot easier. It used to be done with oral naltrexone, but so that's one way to switch people and cover them and make sure that they don't have a reoccurrence during the time that they're tapering those medications down. Okay. And Mark, if you have a minute just to give me a follow-up, a regional database of recovery resources, one-page recovery resources, yeah, I can put that together for you. Again, we're capturing all those things, so if I seem like I'm being glib and just looking over these questions real quick, anything that you don't hear me get back to, I will get back to you on. Yeah, and there can be lifetime limits on MAT medications, but not opioid prescriptions. That is a true statement for commercial insurers. And as we've noted earlier, people are usually in economic distress when they're in the midst of their addiction and don't have you know, a lot of resources financially. So when you see these things about there are things that come out of managed care that say MAT can be prescribed at this level, at this dosage for this period of time after a failed abstinence-based treatment. So there are obviously some things in the field that we need to work on. If I've missed any questions, I will get them to you. And then please, if you want to send something to our core TA folks, and I will collate that. If you have strategies that you've used, as I'm sure you have, I think putting, you know, a couple of hundred people together to figure this out is a lot better than having one person do a webinar. So I'm really looking forward to hearing from you all. These are great questions that y'all put out there. And as we go forward, I just want to say the things that we are doing now can endure and will endure. If you look at 12-step programs and things that have been around for 50, 60, 70 years that are still helping people, I don't think it pays to minimize the work that you all are doing now out in your communities and how you're setting up systems, infrastructure, and services that can be enduring and help people going forward in the long term. So with that, I would say thank you all very much.
Okay, thank you, John. That concludes our Q&A portion. If you have not yet completed the survey, please take a few moments to provide us your feedback. We would like to thank you again for your participation in this webinar, and have a great rest of your day.